Hi, I'm Malika Sharma, and I'm going to talk to you a little bit today about tuberculosis. I have no relevant disclosures to make. By the end of this module, you should be able to identify the etiologic agent, mode of transmission, and pathogenesis of tuberculosis, or TB, describe the clinical presentation of pulmonary TB, understand common diagnostic tests that are involved in diagnosing TB, and outline very basic principles of treatment. And then lastly, understand infection prevention and control measures that are essential in controlling the spread of TB. So first I want to ask you a question. How many incident cases of TB occurred globally in 2013? Is it A, 9 million, B, 5 million, C, 2 million, or D, 650,000? So the answer is actually A, 9 million. It is estimated that another 3 million, in fact, may be undiagnosed, and that of this 9 million, about 1.1 million represent TB-HIV co-infection. In Canada, you can see that although TB rates overall are fairly low, as you can see by that bottom flat line essentially, again, this is one of the infectious diseases that we see really mirrors inequities. So rates are overall higher than in the general population among people who are born outside of Canada, in our First Nations and Métis communities in Canada, and then you can see incredibly high and problematic rates of TB in our Inuit population in Canada. The factors for that are multifold, and I'll talk about that in a little bit. First, just to briefly summarize TB's microbiology and transmission, TB is caused by Mycobacterium tuberculosis complex, and it is transmitted through aerosolization of infectious particles while coughing. 85% of TB is pulmonary, but any pulmonary site can really be affected. I'm not going to go into that in much more detail right now. TB pathogenesis involves, as I mentioned, TB being aerosolized through coughing and then inhaled into the alveoli of a new host. In the lungs, macrophages take up TB, T cells accumulate, and macrophages are recruited to form a granuloma. Once that granuloma is formed, one of two things can happen. In about 5% of people, or more if we're talking about people who are HIV positive, they can develop primary disease or pulmonary infection with TB, which can present as fevers, chills, night sweats, weight loss, coughing, and hemoptysis. However, in the majority of people, about 95%, they will go on to develop latent TB infection, which means the TB is there, they have a granuloma, but they're not having any problems with it. 90% of those people will never have a problem with it and will have no disease. So they have the infection, but no disease from that infection. About 5% of people will go on to reactivate, often in the context of immunocompromise or other risk factors that I'll talk about in the next slide. That reactivation can either be pulmonary or extrapulmonary, and it's also important to remember that new infections may also occur. There are many TB risk factors, and here's a table showing the risk factors and also the fold risk they confer of developing active tuberculosis. You can see that HIV confirms a 20 to 40 fold risk of developing active TB. Something that people think less about, though, is chronic kidney disease requiring dialysis, which is arguably much more common in Canada, and that fact that actually also gives you a much higher risk of developing TB. Then there are things around transplant-related immunosuppression, people who are malnourished, people who have silicosis or lung injury from that, diabetes, smoking, steroid use, and TNF-alpha inhibitors all also confer a risk for TB. This is not a complete list, but these are some of the most common factors. I think it's also important to think about upstream risk factors for TB. So certainly there are the biomedical ones that we just mentioned, but there are also important things to think about, such as crowding, sanitation, poverty, and how these factors are probably much more at play for the inequities that we see among TB distribution in a given population. When we are diagnosing TB, it is very important to be clear as to whether you're trying to diagnose active TB disease or latent TB infection. The diagnostic algorithms are very different for both. The former, or active TB disease, implies that there is ongoing active disease that is making the person sick and is also potentially infectious to other people. That requires treatment for both individual health and also for public safety. The latter, or TB infection, or latent TB infection, implies It is latent, it's not making the person sick, but is at risk of reactivating in the future. It may or may not need to be treated, and involves a discussion of risks and benefits with the patient. When we're talking about diagnosing latent TB, there are really two ways to make that diagnosis. And it's really important to remember that neither of those ways should be used to make a diagnosis of active disease, except in children, which I'm not going to talk about further right now. In addition, we really shouldn't use either of those in people who are at low epidemiologic risk because of the risk of false positive testing that then can lead to inappropriate investigations and treatment. And it's also very hard to interpret a positive test in the context of low epidemiological risk. The one exception for that is if it's being used as a baseline for future screening, so for example, in us as healthcare workers. The two main ways to diagnose latent TB infection are the TB skin test, which involves injecting a purified protein derivative of TB into the forearm and testing it 48 hours later to see whether there's been an inflammatory response, and the interferon gamma release assay, which is a blood test that looks for an inflammatory response in response to TB antigen. There are four main components to making a diagnosis of active pulmonary TB in contrast. One is a chest x-ray to look for any abnormalities consistent with TB infection, which can include a granuloma, calcifications, cavitations. Sending a sputum for direct smear, and that sputum can either just be a directly coughed sputum, it can be an induced sputum using aerosolized saline to try to induce a deeper cough, or it can involve a bronchial specimen, for example, in an intubated patient. That sputum is sent for direct smear and then also sent for mycobacterial culture and drug susceptibility testing. That takes about 6 weeks. A faster way to do this is nucleic acid amplification test. Most public health laboratories have a protocol for when they use these nucleic acid amplification tests. And so, for example, in Ontario, we only do that when the sputum smear is positive. It gets sent for culture and drug susceptibility testing and for the PCR test. If you want a PCR test done on a smear negative sample, you have to call the public health lab directly and explain the rationale for needing that. Once you've made a diagnosis of active tuberculosis, treatment regimens involve an initial phase of 4 drugs for 2 months, and then a continuation phase, typically 2 drugs for 4 months. These drugs include isoniazid, rifampin, pyrazinamide, and ethambutol in the initiation phase, and then 2 more drugs, isoniazid and rifampin, for 4 months after that. This again is talking about drug-susceptible tuberculosis. The treatment algorithms for drug-resistant tuberculosis are much more complex, and I'm not going to go into them right now. The drug toxicities related to these medications are important to consider and include ocular toxicities and, most importantly, hepatotoxicities, which is why, for example, in the treatment of latent tuberculosis infection, it's really important to talk to people about the risks and benefits of treatment. Now, lastly, I'm going to talk about infection prevention and control mechanisms important in prevention of transmission of tuberculosis. So as you recall, it is aerosolized through coughing. So the first and most important piece is airborne isolation precautions. Healthcare providers or people coming in contact with the patient need to wear N95 masks that have been appropriately fit tested. It is also important that the ventilation in the room is appropriate. So a dedicated room that is a private room that is labeled as airborne precautions so people know to wear the mask when they come in. That room also has to have negative pressure, so the air moves in from the hall into the room and then outwards to the outside as opposed to going back into the hallway. Part of that involves a HEPA filter, or a special particulate arrestance filter that takes that outward moving air that's going out of the building and clears it in case it's going to be recycled back into the hospital or go to a nearby building. If those settings are not available, so a HEPA filter is not available, or if you don't have negative pressure, other options include shortwave ultraviolet germicidal irradiation, which is not something that we're typically using here. These are some of the references that were used in the making of this talk, and I encourage you to read further. And by now you should be able to identify the etiologic agent of TB, how it is transmitted, and its basic pathogenesis. You should be able to describe the clinical presentation of pulmonary tuberculosis, recognizing that there are many extrapulmonary manifestations, and also to understand the common diagnostic tests involved in diagnosing TB. I hope you have an appreciation of the basic principles of treatment and understand some of the important infection prevention and control measures necessary in controlling the spread of TB. Thank you for your time, and I hope that was useful.